Okay, so Assalamu alaikum everyone. My name is Dr. Batul Zahra, and today, in partnership with Medical Hub Academy, I'm going to give the lecture on the topic adrenergic antagonist, which is also known as sympatholytics. So, as we have discussed in the last lecture, that sympathomimetics are the drugs which mimics the action of sympathetic system. Sympatholytics actually work in the reverse, right? So that's why they're called as sympatholytic, because they block or decrease the effects of sympathetic nervous stimulation, endogenous catecholamines, and adrenergic drugs. So guys, over here, you can see that there are two types of anti-adrenergic drugs. So obviously, as we have studied in the last class, that there are alpha receptors and beta receptors on the prosynaptic membrane. So when we study about the adrenergic antagonist, obviously the drugs will be going to working on both receptors. So drugs which are going to be alpha antagonists are again two types. They are either the selective alpha blockers or non-selective alpha blockers. So when we study about the selective alpha and non-selective alpha blockers, we can see over here that there are two types of drugs which are non-selective, and they are phentolamine and phenoxybenzamine. And when you talk about the alpha-1 antagonists, which are selectively working on only alpha-1, these are doxazosin, prazosin, terazosin, and tamsulosin. Over here, we can easily remember the suffix "sin", and whenever the suffix "sin" comes in any drugs, we can recognize that these are selective alpha-1 blockers. So we have doxazosin, prazosin, terazosin, and tamsulosin. And now we are going to study about the beta blockers. And the market name of propranolol is Inderal. And if you remember from our last mnemonic, that propranolol comes after the letter M. So obviously, it will be our non-selective beta blocker. So Inderal propranolol is a prototype useful in treatment of hypertension, dysrhythmias, angina pectoris, MI. It is also useful in pheochromocytoma in conjunction with the alpha blockers, counter catecholamine release, and in migraines. So if we remember that phentolamine is also used for the treatment of pheochromocytoma, so along with that, we can use our non-selective beta blocker propranolol as well. And in cirrhosis, Inderal, which is the propranolol's marketed name, may also decrease the incidence of bleeding esophageal varices, because if you have studied the chronic liver disease, you remember that as a result of cirrhosis, there will be several other complications, and one of which is esophageal varices. So to decrease the bleeding, we can use our Inderal. It was also used to be contraindicated in heart failure, but now it's standard. Known to reduce sudden death, often given with ACE inhibitors, like if we are trying to treat the blood pressure in a patient, especially if we have ischemic heart disease. So we can give the combination by giving the ACE inhibitors. For example, we're going to give capitin, and along with that, we can also give beta blockers. So here, as you can see, indications include hypertension, angina, and prevention of MI. Now, receptor selectivity. Acebutolol, atenolol, bitoxolol, esmolol, and metoprolol are relatively cardioselective. So these are the drugs which are basically working on only on the receptors of heart. These agents lose the cardioselection at higher doses as most organs have both beta 1 and beta 2 receptors. So we're going to try to give these drugs in a smaller amount. And beta is the new agent that is cardioselective. So it is also a type of beta selective blockers. And non-receptor selectivity, over here, you can see that catolol, levobunolol, metipranolol, nadolol, propranolol, sotalol, and tamolol are all non-selective, and they can cause bronchoconstriction, peripheral vasoconstriction, and interferes with the glycogenolysis. So first, we have studied about the selective beta blockers, then the non-selective one, and now we're going to study about the combination selectivity. Combination selectivity means the drugs which will going to work on both alpha and beta receptors. And as we have studied before, the labetalol and carvedilol are those drugs which will going to work on beta 1, beta 2, as well as alpha 1 receptors. So it will going to cause vasodilation by working on alpha 1, and it will also going to affect the heart and lung by working on beta 1 and beta 2 receptor. Both alpha and beta properties contribute to the antihypertensive effects and may cause less bradycardia but more postural hypertension, and also leads to reflex tachycardia as a side effect. So if you are going to treat hypertensive emergency along with tachycardia in a patient, so the drug of choice will be labetalol, right? And now the effects of beta blocking drugs. So the beta blockers will going to decrease the heart rate because the beta 1 receptors are present on the heart and kidneys, if you remember. They also decrease the force of contraction, so negative inotropy will going to occur, decrease cardiac output, slow the cardiac conduction, decrease the automaticity of ectopic pacemakers. So if you remember previously that our sympathomimetic drugs are basically increasing the heart rate, increasing the conduction, increasing the automaticity, but these drugs are working in the opposite direction. So we are going to have negative inotropy, negative dromotropy, and negative chronotropy, especially by beta blockers, because they are acting on the heart. And if you remember that beta drugs, as I have told you before, that beta 1 is working on heart and kidneys both, so it will also decrease the renin secretion from kidneys to decrease the blood pressure, but it will also, as beta 2 receptors are present in the lungs and in the bronchioles, so it will going to cause bronchoconstriction, and less effective metabolism of glucose may result in more pronounced hypoglycemia, and early signs and symptoms of hypoglycemia will be tachycardia. Okay. It will also decrease the production of aqueous humor in eye. So if you remember that our adrenergic agonists are basically causing the mydriasis, and they were contraindicated in glaucoma. But as a reverse, as our adrenergic antagonists, especially the beta blockers, are decreasing the production of aqueous humor in eye, so they can be used as a drug of choice in glaucoma, and it may also increase the VLDL and decrease the HDL. VLDL are very low density lipoproteins and decreases the HDL, which is the high density lipoprotein. So this will be a side effect because we know that HDL is the good cholesterol and all the rest are bad cholesterols. And it also diminishes the portal pressure in clients with cirrhosis, which can be a side effect. Now, the therapeutic applications of beta adrenergic antagonists. So number 1 is myocardial infarction. Region of myocardial necrosis caused by localized interruption of blood flow to the heart wall. And migraine, if taken prophylactically, they can reduce the frequency of migraine attacks. So what happened is that our beta blockers are basically, when I told you that they are used in ischemic heart diseases, so I meant MI, because nowadays we are not using beta blockers as a drug of choice for controlling the hypertension. But if the patient has some sort of ischemic heart disease or some sort of MI, then we can use the beta blockers. And then in migraine, we are using beta blockers basically prophylactically. So prophylactically means that we are not using during the acute attack, but before the attack to prevent migraine, right? So it is also used in angina pectoris to decrease the cardiac output. And then for hypertension, beta blockers are the drug of choice for ischemic heart disease patients. Please remember that. And it is also used for patients who are having arrhythmias or dysrhythmias, because by blocking the cardiac beta 1 receptors, there will be decrease in sinus nodal discharge, which means decreased chronotropy, and suppress the conduction of atrial impulses through the AV node, which means decrease in chromotropy. So the alpha blockers will lead to decrease, which means negative chronotropy and negative inotropy, or negative dromotropy. So as a result, there will be bradycardia, reduced cardiac output by decreasing the heart rate and force of contraction. And beta blockers must be used with great caution in patients with heart failure or reduced cardiac reserve. And it is also used in AV heart block, because in AV block, our impulses are not coming from atria to ventricles because of the AV nodal block. So you can use it over there. And it will cause rebound excitation. What is rebound excitation? Basically, increased cardiac activity in response to abrupt cessation of beta blocker therapy. Long-term use of beta blockers sensitize the heart to catecholamines, and if withdrawn abruptly, angina pain or dysrhythmia occurs. So what happens is that if a patient is using the beta blockers for a very long period of time, so the adrenal beta receptors on the heart will going to be sensitized, and suddenly if you stop using the beta blockers, there will be extreme level of increased cardiac activity. So doctors mostly prescribe the patient, if they want to stop using this medication, then you have to withdraw gradually. Taper the dose over a period of 1 to 2 weeks. And also we're going to warn the patients against the abrupt cessation and carry adequate supply of beta blockers when traveling. Okay, so as beta 2 receptors are present on the bronchioles, so when we're going to use the beta 2 blockers, basically the non-selective one, so it will going to cause bronchoconstriction, hence it will be contraindicated in asthma. And it also leads to inhibition of glycogenolysis. So if a diabetic patient requires a beta blocker, a beta 1 selective agent should be chosen. So that's all about the adrenergic antagonist. And if you have any sort of question, please let me know. Thank you so much.